Yeah, okay. So we are going to talk about objectives and endpoints in oncology clinical trials. So first, with a few acknowledgements, we don't really get structured training on this topic in any training program in oncology. So much of what I have learned has been listening to and working alongside some of the leaders in trial design. I've had the privilege of, being a faculty at the Credo workshop, where I have learned from a lot of, people who design very large studies. And also from some grant writing workshops that I have done while I was training in Toronto and through the ASTRO, which is the Radiation Oncology Society. So we are going to, the talk is meant to be a practical guide to how to frame your hypothesis, aims, and objectives, and then deal with endpoints of clinical trials. Now, when a young researcher first writes a research proposal, often these terms can be a bit confusing. So I've tried to make this as simple and as example-based as I can. And we're going to take a practical and specific approach to definitions rather than going by references and more formal definitions. So what is the research hypothesis? When you have to write your hypothesis in a clinical trial protocol, what does it really mean? A hypothesis is an expectation or a belief with which you are doing the study. Okay, so what is it that the trial wishes to establish? The first thing when you have a new drug or a treatment is that whether the treatment A can be safely administered in the disease that you're trying to examine, or a treatment A is active in that disease, or the treatment A is superior to the current standard treatment B in terms of overall survival, or that the risk factor, if you're looking at a study which is looking at prognostic factors or risk factors, whether risk factor B is associated with disease Y. So you're making a positive statement. You're saying that you think something works, something is safe, something is associated with something else. So that is your research hypothesis. Now, once you've got a research hypothesis framed, we now need to write what does your study intend to do. Okay. Now, here a general description would be that my goal through this study is to establish the safety of this particular drug in this particular disease, or establish the efficacy, or establish the superiority of this drug compared to this current standard, or determine the association of a particular risk factor or prognostic factor with a particular disease or outcome. Now, as you can see that once you framed your hypothesis, your research aim is linked to your hypothesis, except that it is framed in a slightly different manner with a more, with some words which express an intention to do something. Okay. So that is what your aim is when you are writing your research aim. What about objectives? Objectives are much more specific goals of the research. And it describes how you are going to achieve that aim. Okay, often specifies the domains or the definitions of that aim, the instruments that you're going to use, the particular endpoints which will be used to measure if the aim of the research is met or not. And usually these are listed in a certain order of importance. So in order to make it much more practical, let us discuss theoretically this, the concept of hypothesis, aims, and objectives. In the context of a fictional drug, I'm going to call it Zabardastumab, a new immunotherapy drug, which you think is going to improve the outcomes in several cancers. Now, before we go into the specifics, a brief revision of clinical trial phases. Why? Because the research hypothesis, aims, and objectives have to be framed according to the phase of the clinical trial that you're doing. The phase 1 trial, as you all know, assesses the dose-limiting toxicities and determines the maximum tolerated dose. It establishes safety. Phase 2 trial assesses the activity in a particular disease and confirms the safety of a phase 1 study. The phase 3 trial, once a drug or a treatment has completed phase 1 and phase 2 and has been successful, in a phase 3 trial, we compare the clinical benefit of that drug versus a standard of care. And in a phase 4 trial, which comes after a phase 3 trial, we verify the clinical benefit and safety in the real life setting. So these are very simple definitions of different phases of clinical trials. So let us talk about each of these phases and what the hypothesis, aims, and objectives might be. So for example, in a phase 1 study of this drug called zabardastumab, what would be your hypothesis? Your hypothesis could be something like this, that single agent zabardastumab is safe in recurrent or metastatic non-small cell lung cancer and achieves plasma levels that can be tested in a phase 2 study. So that's your hypothesis. You're making a positive statement that you think that it is safe and in non-small cell lung cancer. So how will you frame your aims of research? The aim would be to determine the recommended dose or the maximum tolerated dose and the side effects of this drug in advanced or metastatic non-small cell lung cancer. And your objective would be far more specific. You're going to determine for zabardastumab the maximum tolerated dose, the dose-limiting toxicities, and the adverse events based on a certain instrument. In your case, that it could be CTCAE version 5. So if you look at this slide, you will realize that hypothesis, aims, and objectives are related to each other. They are framed in slightly different ways. And as we go along, they become more specific and make use of more technical language. For a phase 2 study, now that, say, suppose you've established the safety of zabardastumab and you've obtained a maximum tolerated dose, what are you going to do next? You're going to now test whether it is active. And the hypothesis would be that this drug is active in a recurrent or metastatic non-small cell lung cancer. The aim of the study would be to determine the response and the adverse events of zabardastumab in the recurrent or metastatic non-small cell lung cancer setting. The objectives would be to determine for this drug in recurrent metastatic non-small cell lung cancer, the objective response rate. Here you're coming to definitions. Objective response rate using what? Using which instrument? Using a particular criteria. Adverse events using the CTCAE version 5. Also look at progression-free survival and health-related quality of life outcomes. So again, you see that for the phase 2 study, your hypothesis, aims, and objectives are related in a certain way. The objectives are changing, the aims are changing, but it follows a certain structure. Why do we want, sometimes, you're not just happy to make a vague hypothesis or a less specific hypothesis that it is active in a particular drug, in a particular setting. You may want to frame a more specific hypothesis. Instead of saying this drug is active in recurrent or metastatic non-small cell lung cancer, you can reframe your hypothesis by saying that it is active with an objective response rate of more than or equal to 20%, or a grade 3 or 4 adverse event rate of less than or equal to 60%. What is the advantage of doing this? Why would you want to do this? Is because you have in your mind a certain threshold beyond which you will take this drug forward in future studies. You may not, if you know that the currently available drugs have an objective response rate of certain percentage, say 30% or 25%, then you're not going to take this drug into the phase 3 study if your objective response rate is less. So you will then, by framing it into the hypothesis, you're making a clearer pitch. You might want to submit this study for grant funding, and there a more specific outcome may be beneficial, especially in competitive studies, competitively funded studies in Western countries. Now, an a priori statement of this criteria maybe need to be fulfilled to consider the study a success, okay, to take it forward into the next phase. And it's also important because it aids in sample size calculations. You don't need to frame it in the hypothesis for that, but at least if you are very clear about the percentage ORR or the adverse event rate, then you will be able to calculate the sample size for your phase 2 study more specifically. Once it is cleared phase 2, a drug would move, or a drug or a treatment would move to the phase 3 trial. Here, the hypothesis may be that this drug improves overall survival compared to cisplatin and pemetrexed in non-small cell lung cancer as first-line therapy, without significantly increasing adverse events. Now, the second part of this sentence may not be really quoted in your hypothesis, but it is very much something that you're looking towards in a phase 3 drug study. Now, the aim of the study would be to determine the effectiveness of substituting cisplatin PEM with zabardastumab as the first-line therapy for non-small cell lung cancer. And the objectives would be to compare this in terms of the overall survival, in terms of the progression-free survival, in terms of the adverse events, again, mentioning the instruments that you're going to use, and in health-related quality of life. So here again, your aims and objectives are changing according to the phase of the study that you're trying to do. With this background, we come to the discussion on endpoints. Now, when we evaluate a study, when we consider a drug or a treatment to be taken forward into clinical practice, you have to define the endpoints or by which you will define your success. Only if it meets certain criteria or endpoints will a drug be considered important enough to be approved by the regulator and be used in clinical practice. So what is an endpoint? Endpoint is something that you're trying to measure. It needs to be meaningful to the patient and or to science, depending on the phase of the study that you're doing. And thirdly, but last but not the least, it can be measured unambiguously. Now, this is an important criteria because it determines what is known as the internal validity of your study. If you set an endpoint which is very vague and subjective, then your study interpretation, the people who are reading your study, will consider this to be an ambiguous study and are less likely to take this into their clinical practice. Generally, endpoints are divided into primary and secondary endpoints. A primary endpoint is usually the main thing that you want to measure. It is what your study is designed to measure. And it's usually only one endpoint. Although this is not universally true, there are some complex study designs or some study designs which have co-primary endpoints, so maybe two endpoints which the investigators can consider to be equally important. But usually there is only a single primary endpoint. All other endpoints are secondary endpoints. They are things you want to measure, but your study is not necessarily designed for it. In terms of clinical practice, it's only your primary endpoint that will be used to determine whether your trial is successful or not. The secondary endpoints are often considered hypothesis generating because your study was not designed to look at it. Although, increasingly in clinical practice, we are looking at studies which are trying to, sell themselves based on their secondary endpoints, but that is not ideal. So what are the different endpoints based on the different phases? In phase 1, clinical trials, where your main concern is safety and toxicity, your endpoints would be the maximum tolerated dose, the schedule of the drugs that you're using or the treatment that you're using, or pharmacokinetic and pharmacodynamic factors that you're going to look at. In a phase 2 or efficacy study, you're going to look at the response rate, disease control, and toxicity rates. In a phase 3 trial, which is comparison with standard of care, you're going to look at survival or variations of survival, quality of life, and toxicity. Now, in a phase 4 post-marketing study, you're also going to look at survival, quality of life, but also look at toxicity in real life, keeping in mind that you may find rare toxicities that your trial did not pick up. Now, preliminary studies, especially in drug studies, you look at target inhibition, drug disposition. But all studies are not drug studies. They could be surgical studies of local therapy, for example, surgery or radiotherapy, where in an efficacy situation, you're going to often look at locoregional control, pathological complete resection or responses, and other similar outcomes or functional outcomes. Now, in a phase 1 trial, the usual clinical trial endpoints are maximum tolerated dose, the dose-limiting toxicities, and pharmacokinetics or pharmacodynamics. In phase 2 trials, the common endpoint is an objective response rate. Now, whenever you're looking at an objective response rate, you have to use standardized criteria. There are several types of criteria that can be used. They are usually clinical, radiological, or nuclear medicine-based criteria. You're looking at complete response or partial response. The definitions of partial response and stable disease have to be taken from that criteria. You have to remember that the objective response rate does not measure benefit to the patient. Okay, it doesn't really matter to the patient whether their tumor reduced by 25% or 50% or 70%. So it's not really a clinical endpoint, but it is very valuable in phase 2 studies because it determines whether your drug can be taken onto a phase 3 study. So from a trial management point of view, an objective response rate is important. Sometimes people use a clinical benefit rate, which is a sum of all the CRs, PRs, and stable disease. Again, you have to understand that some of this is not measuring any clinical benefit. So there are disadvantages in trying to use phase 2 trial endpoints in saying whether a drug is really useful, clinically useful to patients. Ideally, we should wait for more substantive outcomes from phase 3 clinical trials. So what are the endpoints in phase 3 studies? These are what really matters to patients, not the size or the number of lesions, but whether the patients are living longer or living better. And the most appropriate endpoints, which everybody agrees upon, are the overall survival and the quality of life. Everything else is really what are known as surrogate endpoints. What does this term surrogate mean? The term surrogate means it is a pointer. It reflects what's going to happen to either overall survival or quality of life. Usually it's a reflection of the overall survival. So then if overall survival is really the most important endpoint in any oncology clinical trial measuring a treatment that is supposed to improve outcomes, then why don't all trials measure overall survival? Because there are certain practical disadvantages. Survival times can be long in many situations, especially when we are dealing with trials of adjuvant therapy or cancers with a long natural history like prostate cancer and breast cancer, or the availability of good salvage therapy, which can then delay death, which is the outcome of the endpoint of the overall or the outcome measured in the overall survival endpoint. Now, because the number of people dying would be less in many settings of early stage adjuvant therapy or cancers with a long natural history or with good salvage therapy, the number of events you're going to use to measure a difference between the new drug and the standard of care in a particular time period will be low. From the sponsors and investigations perspective, this means that they will require more patients, the sample size will be larger, it will require more time to complete, and of course, it will require a lot more money. And from their perspective, they would say that overall survival would be influenced by subsequent therapy over which they may not have any control. In a study that is running for several years, new drugs would come up, which would be given in the setting of progressive disease, and they would not have any control, or they may find it difficult to compute exactly the number of events that they are expecting. But having said that, it is important to understand that still the gold standard, or the real endpoint that we want to measure, is overall survival. Why? Because not all surrogate endpoints will match up to the real endpoint. Now, before we go to that issue, we are going to discuss a bit about cause-specific survival or other survival endpoints. So what is cause-specific survival? It is death attributable to the disease. So is it death due to prostate cancer or death due to breast cancer? It is the probability of surviving a specific cause of death. Therefore, intuitively, this is a very attractive proposition, because we think that we are looking at something much more specific than overall survival. However, the biggest problem with cause-specific survival is that it ignores death due to other reasons, and those other reasons may not be unrelated to the treatment being offered. So it ignores death due to direct toxicity or indirect effect on other organs. So what are the common surrogate endpoints that are used in clinical trials? In the early stage setting or in the adjuvant setting, we are looking at disease-free survival or relapse-free survival, which denotes either recurrence or relapse or death. Both of them would be outcomes. And usually, as I said, it's used in the curative or the adjuvant setting. In the more advanced metastatic setting, we look at progression-free survival, which is progression or death. We also have several more, so-called SMART or more modified outcomes, which come under the purview of event-free survival. And an event could be anything. An event could be any event or death. They afford certain flexibility. It is more commonly used in the curative setting. An event could be defined by an objective disease. It could be defined by a biomarker or a certain, test rising beyond a certain threshold. It could be determined by function. That is the patient able to speak, or does the patient have a functional stoma? It could be defined by the requirement for a certain treatment. So some of the event-based definitions that you must have encountered are skeletal-related events. They are defined as a pathological fracture or a spinal cord compression or the necessity of radiation or surgery to bone. Or event-free survival is defined by operability or organ preservation, which are resectability rates, laryngectomy-free survival, colostomy-free survival. But before we place special emphasis on event-free survival, we must make sure that these outcomes or endpoints are of benefit or of real clinical use to patients. Now, there has always been a debate regarding which surrogate endpoint is a good surrogate endpoint. And there have been various people who've tried to classify or come up with a set of standards or criteria which define what is a good surrogate endpoint. One of them is the oldest, actually, I think derived in 1989, was by Prentice. The Prentice criteria of surrogacy involves 4 real criteria: that the treatment has an effect on survival time, the treatment has an effect on the surrogate is associated with the survival time, and the treatment effect on the survival is captured by the surrogate. Now, if all of these criteria are met, then by definition, it is a good surrogate endpoint. Now, however, in clinical practice, we have several studies now, or several analyses, which have tried to look at whether some of the endpoints we call surrogate endpoints and use to define whether we are going to adopt a new treatment in clinical practice, whether they really point to the main endpoint, which is overall survival. And this is one study recently published, which looked at the evidence behind surrogate measures included for supporting approval of cancer drugs by the FDA. And they found that there is very poor correlation. In fact, they found no correlation study evaluating the treatment effects on event-free survival with that on. So event-free survival is really a bad surrogate endpoint. The results from correlation studies looking at pathological complete response, disease-free survival, objective response rate, and progression-free survival suggests that treatment effects on none of these surrogate measures were strongly correlated with treatment effects on overall survival. So what is the message from this paper is that we have to take surrogate endpoints always with a pinch of salt. And we should always give more importance to studies, or we should try to design studies which really look at the main endpoint, which is overall survival. Why is progression-free survival not always a good surrogate? Firstly, because progression has limited clinical meaning to the patient if it is not associated with symptoms. This is increasingly common when we are defining progression based on very fancy radiological tests like PET-CT scans, etc., where we find that there's a small progression somewhere. It doesn't matter to the patient is feeling better with the drug, but there is by definition a progression. And also because reducing progression at the cost of serious bothersome side effects is not really clinically meaningful to the patient. So if a drug is improving the PFS, but not improving the overall survival, it's basically causing side effects because of new therapy. The time to progression may be dependent on the timing of assessment, and the association between progression and death may be limited because of various reasons. There's also the issue that, when we are looking at phase 2 trials, we tend to overestimate the benefit of treatments. So again, if you're designing a phase 2 trial and you have obviously designed an ORR or a progression-free survival criteria, you must remember that the magnitude of benefit may not be translated when you do the same study in the phase 3 setting. So the response rates and duration of response were far greater in non-randomized controlled trials than done in randomized controlled trials. So surrogates of overall survival, if I have to summarize, the pros of using surrogates are that faster evaluation, approval, and availability to patients. There is a likelihood of more events, therefore smaller sample sizes, and they are unaffected by salvage treatments. The cons are it gives a false impression of clinical benefit to patients. There could be some bias in reporting them. The timing of the event can be uncertain or manipulated based on radiology reports, and there could be a censoring bias. So when we are defining endpoints, we often use certain ratios like the hazard ratio and confidence intervals to define our success. So we may define the success of a study based on a certain hazard ratio. So very quickly, it's a comparison of the risk of developing an adverse outcome in the experimental arm versus the standard arm. It is akin, but not really identical to relative risk, and it represents an instantaneous risk over a short time period. The hazard, when we say that the hazard ratio of death is 0.8 with a certain confidence interval, it means that at any unit time interval, the ratio of a probability that a person will die in the study group versus control group is 0.8 and can be as low as 0.7 or as high as 0.9. Finally, we come to patient-reported outcome endpoints. It's important to choose validated PRO instruments, for example, the URTC quality of life questionnaires. The choice depends on what instruments to use, depends on the clinical questions. And your question can only be answered if it is covered in the PRO. So you cannot answer certain questions on clinical endpoints or patient-focused endpoints if it is not covered in the instrument that you're using to measure the patient-reported outcome. And always, it should be the goal to define a clinically meaningful response criteria in terms of the patient-reported outcome a priori, that is before the trial is started. So you just can't say that I'm going to measure the quality of life and we're going to report. We should say that we are going to consider the quality of life improvement as clinically significant if there is a 10-point improvement in a particular subdomain. So that makes your study a lot more externally valid and more likely to be adopted in clinical practice. Now, dealing with patient-reported outcomes can be complicated, so it's good to reach out to senior researchers who worked with PRO endpoints in order to define your study outcomes better. In terms of observational studies, they're often studies of association or correlation, and common endpoints that are used are odds ratios and sometimes relative risk. We are going, I'm sure that, Sadhana is going to discuss how to calculate sample sizes and how to look at these outcomes in a future trial, in a future talk. So thank you, and I'm happy to take any questions.